Okay, so thinking about this electrical behavior of the myocardium, this is sort of what will happen when we get that electrical potential. And follow what it's trying to show you here on the chart, showing us that those voltage gated channels are going to open, and we're going to find that that depolarization occurs rather quickly. The sodium gates close, and this is that plateau that I mentioned, as that allows for the blood to be ejected from the heart. And then as we begin to see those calcium channels open and then calcium channels close, we begin to see repolarization taking place. And note this, it's a pretty long absolute refractory period, meaning that that heart is not going to fire again, because what it needs to do, it needs to go back down to the resting membrane potential so that it can then start the process again for the depolarization. Now, a way that we know about this electrical behavior of the heart is from an ECG. I've always had, known it as an EKG, but this is the way that we, look at the beating of the heart. And the EKG, the ECG, I'm going to call it the EKG, okay, you guys? When an EKG is run, okay, it records based on those electrodes that have been placed on the arms, legs, and chest, and it's basically recording the action potentials. Now note, it's the action potential of the nodes and those myocardial cells. So when an EKG runs and we get the tape, the read from the EKG, what we end up getting is, under normal conditions, we get this nice formation of the waves. And so what this is referred to, okay, we have our P wave, we have the QRS complex, and then we have the T wave. Each one of these, P, QRS, T, then what they note as the intervals, every single one of them can tell a doctor something about the beating of the heart. So if the EKG does not look like this, it's not normal. And because doctors know how to read these EKGs, they will know where to begin to look for different problems. So when you look at that EKG, the P wave lets them know about the firing of the SA node. So we're beginning the depolarization. When we have the QRS complex, the ventricles begin to depolarize. In the P wave, it belongs to the atria. In the segment from S to T, this is where the ventricle will be in systole. And then the T wave is where the ventricles begin to relax. So when an EKG is done, it's known by the cardiologist, and trust me, I am not a cardiologist, okay? But this electrocardiogram, when they read it, they can actually determine, well, this correlates to the atria, or it correlates to the ventricle. It correlates to relaxation. It correlates to contraction. So they will be able to read that EKG based on what it's associated with on the heart. For example, in these pictures over here, they're trying to show you the P, QR, S, T, the intervals, the R's, and that's letting them know what part of the heart it belongs to. So if we look, for example, at the P, and note they're trying to tell us depolarization or repolarization. So here we're going to see under the P wave the depolarization of those atria. And then if we begin to look at what happens with the atria as the depolarization occurs, okay, then we begin to note the ventricles. If we note the ventricles and then the atria relax, ventricles begin to contract, ventricles contract, ventricles will begin to relax, ventricles relax, and we start the process all over again. And they can actually take an EKG that's been done and they can determine, all right, is this EKG normal or is it abnormal? And if so, what is wrong? So any type of deviation from that normal EKG, it will let them know something about the heart. Do we have an issue with the conduction pathways? Has the person had a heart attack? Do they have maybe a chronic condition or an acute condition that could be leading to enlargement of their hearts? Could it be that electrolytes might not be correct? Might be some hormones that are affecting the heart. So when we begin to look at things that can go wrong with the heart, when something goes wrong with the heart, we call it an arrhythmia because it's no longer in rhythm. And so one type of arrhythmia that's pretty serious is ventricular fibrillation. This one means that those electrical signals, they are not following those bundle fibers, the Purkinje fibers. Basically, those electrical signals are traveling very randomly, and therefore the heart is not going to contract normally. In other words, at the base of the heart where that looks like that twisting motion is going to start, that's not where the twisting motion starts. It's usually indicative of a heart attack. And if the heart is not brought back into its normal rhythm very quickly, it can lead to death. So usually that's when you see them bring out the paddles, and the paddles will be used, and hopefully that electric shock to the heart is going to help set it back into a normal sinus rhythm. Now, granted, sometimes this takes several times for the heart, okay? And usually you have to go about finding what is wrong and correct the problem. Now, in some cases, especially in areas like artery disease or maybe some other chronic conditions, it might take surgical procedures, might take medication, okay? There are different things that they've done now to help with these arrhythmias in the heart. Some other arrhythmias that can be noted on these EKGs, one is called heart block. And this is where that conduction system, basically the passing of those electrical signals, it's not occurring. Those signals are not making it from atria from the SA node to the AV node to the bundle to the Purkinje fibers. And so this particular EKG is showing what would be indicative of heart block. And doctors would be able to see that, and they'd be able to begin diagnosing the problem. Down here, this one right here is showing, most likely the ectopic focus, where the beat is starting somewhere else other than the SA node, and that's affecting the contraction of the heart, of the ventricles. Now, one of the things that happens with the fluid in the heart and basically the flow of the fluid, we're going to find that pressure plays a major part in how the fluid flows. And pressure can affect the flow and the resistance. So one of the things that has to happen, the pressure and the flow, we have to have a pressure gradient for fluid to move. And usually, the fluids are going to go from an area of high pressure to low pressure. And the way that we can measure this is with a sphygmomanometer. This is what we use to measure blood pressure. Measuring blood pressure helps to know a little bit about the pressure being created in the vessels. And then what is that pressure doing to the heart? When the heart is pumping hard, okay, and the pressure is high, that's going to actually create a problem on those arteries coming off of the heart. And the pressure can actually reach such a level that they might burst. So one of the things that happens when we create these pressure gradients, or maybe I should say when these pressure gradients are created, the pressure gradients, we have stuff that's going to occur on the left side of the heart as well as stuff that'll happen on the right. Now, on the left side of the heart, this is the side of the heart that we have to have the blood flow to the rest of the body. So, pressures that are going to be present. If we look at the left side of the heart, the ventricle, and if you remember from the pictures, it's very thick with the myocardium. Now, when the ventricle gets to relax, it will expand. When that takes place, the pressure in that ventricle drops. If the pressure drops, the mitral valve can open, and that's going to allow blood to flow into that left ventricle. As that ventricle fills up with the blood, that is going to affect the pressure. The pressure is going to begin to increase in that left ventricle. When that pressure reaches a certain point, those AV valves that were allowing the blood to flow from the atria to the ventricle, those are going to close, and then the aortic valve, the semilunar valve, will get pushed open, and when the heart contracts, the blood will get pushed into the aorta from that left ventricle. So those pressure changes actually affect the opening and the closing of these valves. And that is important because that is actually allowing the blood flow to take place, whether we need the flow to occur from the atria to the ventricle or from the ventricle into the vessels. So if we look at this picture right here, note they're trying to show us the filling of blood into the atria. And so they're showing this right atria, and it's filled with blood. Now, this right ventricle right here, it's open, it's relaxed. And so therefore, the valve, the atrioventricular valve, is going to be open, and the pressure that builds up in the atria, the blood will begin to flow into this ventricle. As the blood flows into the ventricle, the pressure right here was low, but blood begins to flow, and therefore, and they're trying to show it on the left side also. So if we watch how the blood begins to move into these ventricles, the pressure that was low now increases. And because the pressure has now increased in these ventricles, it causes the atrioventricular valves to close. Now, the only other place is to open the semilunar valves. So move down here to this picture. The pressure is now high in our ventricles, and in the right ventricle, the AV valve has closed, the pulmonary semilunar valve has opened. Over here on the left ventricle, the aortic semilunar valves are going to open. And then when that heart contracts, when it does that beat that we think of, this begins to get pushed into the vessels, which means pressure begins, the ventricles begin to empty, pressure begins to decrease, and when the pressure begins to decrease, the valves are going to close, and that's keeping it from backflowing into the ventricles of the heart, and now it will begin its passageway into either the systemic circuit or into the lungs. So those heart valves are extremely important in the blood flow, and then the pressure gradients affect those heart valves.